Okay. Besides the insurance, some overall kind of a more multimodal approach to pain management for our patients after surgery, changes in our patients and their expectations of what they what is acceptable to them in terms of recovery and function. In some cases, uses of wearable technology that allows for better remote monitoring. Certainly the COVID pandemic has played a role. Optimization and overall risk stratification for joint replacement patients. Use of TXA, which has significantly changed the rate of transfusion after surgery. And then in some cases, surgeon factors as well. So from looking at this kind of through a macro lens, starting around 2010, I began to see a lot of studies published looking at use of tranexamic acid and multimodal pain regimens in joint replacement, showing significant reduction in rates of blood transfusion and better pain control for patient with less opioid-related complications or adverse events. A big one, too, is that in April 26, Center for Medicare and Medicaid began their bundled payment initiative for joint replacement, which was not mandatory for every hospital, certainly, but for those that did participate, really shifted a lot of the focus about what we do during the episode of care for a joint replacement and the value of that, considering that the cost for the overall episode of care was limited by them, penalized for higher cost and in some cases incentivized to spend less. In January 2018, Medicare removed knee replacement from their inpatient only list. And in 2020, hip replacement followed. So meaning that they would then pay for Medicare patients to have surgery, hip or knee replacement surgery, either in the outpatient setting or in the inpatient setting. And I think all of us have seen that now sometimes a peer-to-peer is required if you are planning a routine, at least in the eyes of the insurance, a routine primary joint replacement as an inpatient status procedure. And then we all know March 2020, COVID-19 pandemic began, elective surgeries, many were canceled right off the bat for several months, and then kind of lingering issues with bed availability that we still see today. A little closer to home here, speaking of the bed availability, we know too that if the inpatient census is too high, sometimes elective cases the next day will be canceled. I think at least here, we're not quite to the, if my patient stays, I have to cancel a case, but that is true in some centers. And then I think it, really begs the question of what are we doing for the patient in the inpatient setting? Is the cost worth it, and how necessary is it for patients to be here? So, and there have been several studies that show that routine post-op labs not necessary for patients after joint replacement, unless there are specific medical comorbidities that require it or specific other clinical findings that warrant it. And then especially with the widespread use of TXA, a significant decline in the rate of transfusion. You can see there compared to 2011, basically for primary cases has completely dropped off. Additionally, our patients are getting younger. They are, I think, having higher expectations about return to function and return to function sooner. Some of that also includes return to work, which I think is an important consideration. Just less acceptable for them to, spend, I mean, certainly 2 weeks in a hospital, but, spend a long time in a hospital and then in a nursing facility afterwards. They want to get back more to their regular life. And then especially with the pandemic, a lot of platforms have cropped up, allowing for better remote monitoring of patients. Some of that is app-based, some of it is driven by industry, and some of it involves wearables like Apple Watches or the like, which I think we are, as younger patients are more willing to do this, but does allow for patients not to have to come and be seen face-to-face either by us or by other people in the care team quite as often. And there are obviously pluses and minuses to that. So obviously the primary concern is it safe to do this. This study was an award paper in 2017 looking at patients randomized to either outpatient or inpatient hip replacement. All the patients in this study were anterior approach hip replacements done with the same type of anesthesia and at the same hospital-based facility. They reported a rate of 76% successful same-day discharge. You can see their inclusion criteria listed here on the right side of the screen. And they did also report that there was no difference in the number of readmissions, reoperations, ER visits, acute office visits, or number of phone calls or emails to the surgeon. So they felt that this showed that this could be done safely in a selective patient population. Things you'll notice that are kind of consistent throughout the studies that we'll look at are patients included with a BMI less of 40, age sometimes and sometimes is not a consideration, unilateral primary procedures. And then they did not in this study talk about specifically about caregiver availability. Looking at a different patient population, this study is out of Denver Health, looking at doing same-day joint replacements in a safety net hospital population, which tends to, as we all know, have a higher comorbidity burden, and sometimes a different insurance mix. So they looked at a cohort of 131 patients, 97% of which were able to successfully achieve same-day discharge from their hospital. They did note 1.5% readmission rate and 13% rate of 30-day ER visits, but felt that this showed that they could do this successfully in with their patient population, and that may financially allow this program to persist there, which is obviously a huge issue. We're thinking about access to care for patients, and looking at the patients that they did indicate for it, similar to the last one, unilateral primary procedure, lower BMI. They had age under 70. It was 75 in the previous, and then they did say specifically that they required 24-hour caregiver availability for at least the first 2 post-operative days. And then finally, this study specifically looking at liberalizing their inclusion criteria for people having same-day surgery as a result of limited bed availability during COVID. They basically took anyone who was not having a non-elective hip or knee replacements or a bilateral procedure, really, established protocols with respect to patient and caregiver education, ensuring aggressive PT, multimodal pain control, spinal anesthesia with limited use of bupivacaine, and no intrathecal narcotics. And they did find that comparing patients done prior to COVID and those afterwards, no significant difference in rate of ER visits, readmissions, or reoperations. So I think overall, it does show that this can be done safely. Obviously, have to take care to think about each patient individually and whether or not they are appropriate in their situation to have this done. Surgical factors, obviously, too, are important. Straightforward, what does that really mean? I guess it depends on who you ask. I would say for me, not something where I'm taking out hardware or having to have multiple plans of what we might do during the surgery. But in general, unilateral primary procedures. I think the discussion with the patient and their family about social support and their goals is really important. They have to buy in as well. And then sometimes objective metrics can be helpful too. And I think those are starting to become more popular. So this was really the first one that was published, this so-called OARA score, or outpatient arthroplasty risk assessment score, from Indiana University. This was developed with, I believe, with the anesthesiologists and the internal medicine doctors as well weighing in, basically creating 9 comorbidity areas containing specific conditions that they then scored for each patient based on the presence of each condition, severity of it, and the medical optimization status. And these numbers were tallied, and a lower score is better. They initially said that a score of 59 or less is safe for early discharge, but published a follow-up in 2019 saying that less than 79 would be safe for a same-day discharge. You can see the numbers listed there on the right side are quite high. And I think this is a fairly cumbersome way to classify patients for most people. And I think because of that, it's not widely used. The RAP score, I think, is a bit more popular, looking at more of a less about medical comorbidities and more about patient mobility and kind of social status. So this study retrospectively looked at about 20,000 hip and knee replacements who had same-day surgery, specifically looking at those that were done prior to the changes in the inpatient status for hip and knee replacement compared to those done afterwards. And they did find that overall the RAP scores were lower after the hip and knee replacement were removed from inpatient only status. They found also that a RAP of 10 correlated with likelihood of success with a same-day discharge. 9 was predictive of a one-day stay, and 8 or less was predictive of greater than one-day stay, and made the comment that perhaps insurance was driving patients with lower functional status and social support towards same-day discharge unfairly. So I think that is an important point to consider, but obviously this is limited to, and the RAP certainly doesn't take into consideration all patient factors. So costs, right? How do costs compare for inpatient versus outpatient joint replacement? It's hard to find direct head-to-head comparison. Obviously, payment is very specific to each facility and each insurance type. But from what is available right now, this is an older study from 2014, I believe, looking at patients who had knee replacement from 1997 to 2009. So a fairly long time ago now. And at that time, the standard of care was 3 to 4 days in the hospital after surgery. They found that those patients who were considered outpatient or same day, and those who had a 1 to 2 day stay did cost less, $8,500 less than those who had the standard length of stay. So not a insignificant number. This is the same group, also published in 2014, looking at hip replacements only, done by a single surgeon. And they noted about a $7,000 cost difference between those who had outpatient surgery versus those done inpatient. Interestingly, they did also note that the outpatients who did require inpatient conversion somehow only costed $200 more than those who were discharged the same day, and didn't really make a comment on that. So I guess take that for what it is. But I think if we think about the number of patients who undergo hip and knee replacement every year, $7,000 or $8,000 per patient is not an insignificant amount of money. A more modern paper here done in Canada, looking at primary hip replacement done at a single hospital center by a single surgeon. Patients were randomly assigned to either same-day discharge or a one-night admission. And they found that outpatient procedures had a lower direct cost to the healthcare payer, and then a lower cost in terms of societal costs, thinking about unpaid time off of work, unpaid time off for caregivers and assistance needed. So I think that maybe the absolute dollar amount is not quite as important as overall looking at what is the cost of someone staying in the hospital for multiple days, especially if we're not really providing many inpatient necessary services for them. So one of the things that I was asked to do when I came back to work here was to start doing hip and knee replacements at the outpatient surgery center, which is a bit of a different animal than doing it in the hospital. So that has been an interesting challenge, getting that together over the past year. Looking at, again, at the AJRR from 2022, you can see a humongous increase in the number of joint replacements being done at a surgery center over the last 10 years, from literally 5 to now over 22,000. Interestingly, I think the academic medical centers in California have been slow to adopt this, especially compared to the rest of the country and compared to our private practice colleagues. Only UCLA really has this in place now to do even same-day discharge from the hospital or surgery done at an outpatient facility. And then around the Bay Area, though, this is more common among the private groups and certainly with the Kaiser practices as well. San Jose also does have a outpatient surgery center for Kaiser where they do joints too, though mostly that's done in the hospital setting. So for us here, basically how the process has worked is that we are taking patients who are indicated for hip or knee replacement. I discussed the possibility of doing same-day surgery for those who kind of pass my sniff test, look at them as someone who, yeah, you could maybe do it, probably talk about their social support and kind of get a read for how they feel about it. So I decide at the time of booking if they are to be done at the surgery center or the main OR. They are then seen by anesthesia for their standard pre-op review. The OSC patients then are either green lighted or redirected to the main OR if there's some sort of a concern about safety from the anesthesia perspective. So we did establish these absolute exclusion criteria. This one at the bottom, poorly controlled diabetes, A1C greater than 8 is contraindication for surgery in general. So, but the rest of these are, conditions that either need inpatient care, increased monitoring, potential for blood products, or just a higher overall rate of complications. And I would say for me, a big one here is lack of social support at home. That patient's not going to be successful, and the risks of a fall or another problem are just not worth it. Relative exclusion criteria is age over 80, BMI over 35, other severe cardiac or pulmonary disease, OSA, any mobility disorders or neurologic impairments such as Parkinson's that may affect their ability to mobilize, ASA class greater than 2, and then certainly revision surgery, though I have not really tried to push the boundaries on that yet. Maybe not advised. So specifically papers looking at same-day discharge from ambulatory center. This study looked at the, disqualifying conditions and how much of the population might be appropriate for surgery in the ambulatory setting. So looked at 3,400 joint replacement patients, exclusion criteria fairly similar to ours, though they some differences, I guess specific that we don't in general run across too often: age under 13, ASA 4, fairly obvious, any infection requiring contact precautions. They did green light ASA 3 patients if they did not meet any exclusion criteria, and also if they did not have any other significant medical comorbidities. So that's fairly similar to us. They found that 70% of these patients were eligible to be done at an ambulatory center, and 35% of the ASA 3 patients were eligible to be done there. So I think a fairly large percentage of the joint replacement population could potentially be done at an ambulatory center. And this is coming from an academic medical center as well. But notably, they did not report on their readmission or complication rates. From a different group, they looked at 3,000 outpatient hip replacements only, all done by the same approach, same type of anesthesia. They were about a 2-to-1 rate of hospital cases versus ambulatory center cases. Readmission rate 2 from the surgery center, 9 from the hospital. ED visits 3 from the ambulatory center and 2 from the hospital patients. So overall, they found no difference in joint-related adverse events or unplanned visits between the 2 patients. So obviously, this was retrospectively done, so the patients were pre-selected for ASC or the hospital, but just showing that it's not significantly more dangerous or more likely to result in adverse events or unplanned visits to have the surgery done at the ambulatory center. So my experience with this, as a resident, we did the first same-day hip replacement in New York City, which was a big deal at the time. But that really was, very interesting for me to see the differences in the patients who were able to go home and those who were not, and the amount of planning that had to go into making this process safe and more streamlined from the standard post-op recovery at the time. At Kaiser in Northern California right now, the rate of joint replacements who go home the same day is approximately 85%. And I would say in general, the kind of overall feeling is that if a patient is optimized for surgery, they are optimized for same-day discharge. Obviously, you know, a Kaiser population is necessarily a little bit different than tertiary care referral center population, but for the most part, you know, I was surprised at the patients who were able to successfully do it. We would not plan pre-op for anyone to go to a SNF. They had to demonstrate failure of progression with PT and a true need for it. And then I would also review the same-day discharge protocol with the patients when they were indicated for surgery, ensure that they were on board and had kind of bought in, which I do think is very important. And then at least for me in my practice, all of the surgeries were done in the hospital setting. So that was a nice backstop for those who were not able to be discharged home. Fairly easy to find them a bed upstairs. They stay overnight and go home the next day. It was not a problem, which is obviously different in an ambulatory center. So here basically talked about the anesthesia determination of site of surgery. After that, patients who are green lighted for the OSC do have their pre-op visit with the physician assistant. They get a series of screening pre-op labs. They get their prescriptions ahead of time. Any equipment, we do caregiver education, just talking to them, making sure that the support person is on board and knows what to expect. They also speak with our physical therapy team and case manager as well, just to identify any other issues that might be at play. On the day of surgery, I do give them a carbohydrate drink to have 2 hours prior to their arrival. I would say the evidence on this is mixed, but if nothing else, they tend to feel a little bit better. So why not? Probably not going to hurt. Pre-op medications all given. You can see them there on the right. For certain patients, we will hold some of them. We have also started to give the antibiotics in the pre-op area. For the vast majority of our patients who get cefazolin, we want it complete 30 to 60 minutes prior to skin incision. Patients who have a positive MRSA swab on their pre-op lab workup get vancomycin and cefazolin. So the vancomycin is given even earlier, meant to complete 60 to 120 minutes prior to skin incision. Reason for this being that we want the concentrations to be high enough to really provide prophylaxis for the patients. And then there is good evidence that then a second dose is not needed. So no need to, especially for vancomycin patients, keep them for 12 hours after surgery for that second dose. Spinal anesthetic is preferred. We are, using mepivacaine for the vast majority when there's not a shortage. And we do spinal for everyone unless the anesthesiologist is unsuccessful or there's some other specific reason. And then also doing a single shot adductor canal block for the knee patients. So in general, on average, patients are spending about 4 hours in the recovery room. I do get a post-op x-ray on all of them. Our physical therapist will come and see them, get them up to walk, do gait training, stair training as well. And then if the patients meet all the criteria, they are discharged into the care of their support people. And then we do reach out to them on post-op day 1 to check in, make sure that they were able to get all their medications successfully and no other issues have cropped up overnight. So, in getting this set up, wanted to try to minimize the amount of equipment and I guess learning for the staff there. So decided to just do anterior hip replacements, total knees and unis. Do use a surgical robot there. I do have no implant or procedural differences with cases that are done at the main OR versus those that are done at the surgery center. And that was important to me because the site of care shouldn't, be determining the quality of what I'm doing surgically. And then did build the so-called just in case cart, which we hope we never need, but it was always important to have. So this ranges from incisional wound vacs, knee braces, hernia mesh and vascular clips, which I hope I never need there. And then some different implant options just in case something unexpected happens. Flexible reamers and a small frag set as well, some of this already was there in place. Some unanticipated challenges that cropped up from an equipment perspective was that there initially was no 12-inch C-arm there, which I do use for all of my anterior hips. So we were able to get that actually fairly quickly, which was very nice and necessary. The consignment trays is still an ongoing issue, mostly from a storage perspective at the surgery center. I've been told. Ideally, I would love to have sets there so that they can really be streamlined and help kind of speed up the process of getting set up and opening trays for the case. As you all know, the 23-hour stay is not available on an as needed basis at the surgery center. So that is not a backstop for our patients who are not progressing appropriately. I found recently that among the anesthesia providers, there's a pretty good variation in what medications they give during surgery and in the PACU, and a heavier reliance on narcotics, especially by people who don't normally work with joint replacement rooms here at the main hospital. So sometimes patients are getting over sedated, which obviously prolongs their time in the recovery room and leads to nausea, vomiting, and other issues. Dedicated OR team, I have a fairly consistent group that I work with, although there has been a lot of turnover lately at the surgery center. And I think that's an issue everywhere. And then this last one actually was a bit of a surprise to me, but just an overall lack of institutional and community awareness that we are doing this. So that is something that I have been working on over the past several months too, just to make more referring providers aware that this is an option for joint replacement patients. So by the numbers, as of Monday, I've done 71 surgeries at the outpatient center, 43 hips, 22 knees, 5 unis and 1 manipulation. 94% of them have successfully gone home on the same day. I've had one 90-day readmission for acute PJI at 3 weeks due to an unusual bacteria. What are these uncomplicated cases, so-called, that we're doing? I think it varies. This is a fairly stiff varus knee, not anything else particularly complicated about it. This is a lady who had a failed lateral plateau fracture. Hardware had previously been taken out. This is an older woman who had a non-op proximal tibia fracture and a pretty significant varus deformity. Some hip dysplasia, and then more severe hip arthritis too. And all of those patients were able to go home safely. So looking more critically at those who were not able to leave, 2 hips, 2 knees. I tried to kind of parse them out into a type of failure. Failure of indication. So this first one, she, I don't know, I guess she fooled me when I met her in pre-op, but basically she refused to get up and walk. She ended up staying 6 days in the hospital, was initially demanding to go to a sniff. We talked her off that ledge, fortunately, but just was really not mobilizing at all. The second patient actually admitted to me on the night of surgery that she was unwilling to do PT that night and had never intended to complete the same day discharge, but said that she was so that she could have surgery more quickly. So there's that. Failure of nursing. This one I think really should not have happened, but this was a knee replacement patient who was transferred to the ED at 5 p.m. For planned admission, but the patient was discharged to the ED from the ED after ambulating, and orthopedics was never called. So there's no reason for her to have gone and waste the ambulance ride to the ER. And then this last one, I guess, failure of anesthesia, plus minus, I guess you could call it that, but had severe nausea, vomiting, and dizziness that precluded her ability to participate in PT. So patients 2 and 4 did get admitted here at the main hospital, and both were able to be discharged the next day without issue. So looking at them in a bit more detail, you can see nothing particularly notable about their age, BMI, ASA class. RAP score for this patient, who is the one who told me she was never intending to go home, a little bit lower than what we like to see, but then comparing to For other patients who did successfully complete same-day discharge, you can see that they all had somewhat similar RAP scores. So obviously that's not a perfect metric in determining who's a good candidate or not. In the literature, looking at reasons for failed same-day discharge, this one's out of Rothman, fairly similar. So their number one reason for failure of same-day discharge was patient preference, also dizziness and low blood pressure and inability to clear PT. They also had reports of urinary retention issues and pain management issues, and also found that other comorbidities that were associated with the failure of same-day discharge were patients with multiple allergies, history of sleep apnea, history of rheumatoid arthritis, and then comorbid anxiety and depression. So take it for what it's worth. And right now, some research that we're working on is trying to identify if there's any objective differences in patients who are having surgery at the OSC versus in the main OR. Something better than a sniff test really to determine if they're a good candidate or not. So comparing patient group demographics, doing a RAP score on them, and then specifically looking at the timed up and go test, using a transcutaneous monitor to see if that is an independent predictor of OSC versus main OR destination for surgery. So thus far, unfortunately, most of the patients enrolled have had surgery at the main hospital. So obviously working on getting more of the outpatient patients involved in the study. But, from what we have thus far, compared to some of the other factors, the tug time or timed up and go does seem to be a reasonable differentiator. Interestingly, I think probably the most interesting thing about this is at the far right corner here circled. These are all patients with fairly similar RAP score, fairly similar tug times. All of the outpatient surgery center patients are clustered over there. So I think is going to be important to parse out what differences, if any, exist between the surgery center and the main OR patients. And if there aren't any, then perhaps we should liberalize our use of the outpatient center and do more surgery there for patients who are appropriate. So like I said, enrollment is ongoing. Obviously, we need more patients overall, and especially more of the OSC patients. And I think will be interesting to see if that does become an objective differentiator that we can use, especially because it's a fairly easy thing to do and calculate at a pre-op visit. So I would say from my perspective, and I think the literature supports this, that same-day discharge is safe for many joint replacement patients. I don't think we'll ever get to a place where every single patient is going to be having surgery same day, especially as our patients get sicker too, especially at referral centers. But I think the vast majority of the average joint replacement patients are able to do this safely. It does require quite a bit of planning ahead of time, getting protocols in place, having team members available to patients so that they can contact us. And I do also think that anesthesia buy-in is critical. And, I think we are seeing too that these surgeries can safely be done at the surgery center, even for the appropriately selected patients, even with, not a same site backstop in place for those who fail. And I do think that moving forward, we are going to see more and more issues with insurance not wanting to pay for surgery done on an inpatient basis. And perhaps we may get to a point that indicated for surgery means indicated for same-day discharge. Obviously, there's going to have to be a large culture change, both in hospitals and among surgeons and other support staff and team members involved in this, and then also with patients and their expectations as well. And then we will see, I guess, the implications for cost savings, though, as I mentioned, that is very site specific and kind of nuanced in how that's calculated. And that's it.